Thanks for putting up this very important symposium dedicated to personalized pain management. I very much appreciate that, and I would like to present a little bit background and evidence about why this is very important for the future. So the conflict of interest declaration here from my side, and I would like to start with very, very old data, showing you that from different countries and different time frames, starting in 1995, going up to 2015, basically, there are many patients suffering from post-surgical pain. More than 30% of patients have moderate to severe pain intensity ratings, meaning that this is too much for us, basically, as anesthesiologists watching this patient. So we have to do something, and there have not been many changes related to these issues. And there is, in the recent past, one other issue coming to this, which is chronic post-surgical pain. So about 10 to 30% of patients, 3 months or 6 months after surgery, ask for pain, say, yes, I still have pain after surgery and I had no pain before surgery. And this relates, and I will show you some data, to acute pain and acute pain management in the perioperative period. And last but not least, and this is a topic of the last 5 years, and it comes from the US, but it's in Europe a little different, but not much, and we do not have so many data about that, but many patients take opioids 6 to 12 months after surgery. And we need to figure out why, and this is one aspect. It's very individualized that we are talking about today. We did a very large study that was led by Dominic Fletcher from France, but it involved more than 20 hospitals in Europe and more than 2,000 patients. In fact, 3,000 patients initially have been included in this study. And from these patients all over Europe, 30% of patients, again, said they develop chronic pain after surgery. 30% 6 months, and even 25 to 30% 12 months after surgery. So in Europe, we have the same or similar problems than everywhere, and we have to check what is behind that. And one aspect we already know exactly from this study. Asking the patient very early after surgery, it looks like that those patients that experience pain within the 24 hours after surgery, most develop the highest risk for chronic pain after surgery. As you mentioned, we are able to ask the patients after surgery, but we have no idea what happens during surgery. So this is basically a black box, and we do not know if during surgery nociception leads to chronification of pain. And so severe pain after surgery, as well as the type of surgical procedure, seems to be related to the development of acute pain, high acute pain, and chronic post-surgical pain. And I show you some data. These are not very new data, but these are the biggest data from Europe, showing you that we have some surgical procedures that produce higher pain scores than other surgical procedures, and these are data from 50,000 data sets from European patients. And here it is important to realize that not only the high-impact surgeries, like big back surgeries or some orthopedic surgical procedures produce pain. Some lower, minor, or moderate surgical procedures produce some pain as well, like tonsillectomy, cholecystectomy, or other surgical procedures. So we have not to put our effort only in the high-impact surgeries, but also in the low-impact surgeries. What we are doing as anesthesiologists, we are trying to reduce pain after surgery by, of course, using opioids. We cannot avoid at all opioids. We try to reduce opioids, but some opioids are still needed. But we can avoid opioids if we use regional anesthesia techniques. And this has been shown in many, many studies that, of course, this is one technique that reduces acute pain after surgery, and we know from nowadays that it reduces the risk of chronic pain after surgery. And these are, again, data from the European data supporting that. However, looking at just one surgical procedure, 150 patients, as I show you here, the median pain score is okay by having acute pain 6 hours after surgery with a 5 or 50 out of 0 till 100, going down after surgery, the days after surgery. This looks not too bad, but looking behind that, every individual patient has their own pain intensity score. And why are these patients here not as good as the other patients down below? This is one very, very important question, and we are not entirely sure what are the risk factors and why these patients develop more pain, acute pain here in this case, than others. And we have tried to figure that out with some large databases again. This is another European study, Pain Out, where we have looked into risk factors for high acute pain scores. And we identified, and it looks very weird, the next slide, so just to show you, and this is the conclusion, that we found 3 major risk factors. One is preoperative chronic pain, so the patient going into surgery already with pain. The next one is young age, and the third one is female gender. These 3 basically independent factors are unrelated to the surgical procedure, always a risk factor for high pain intensity scores. And we try to develop a risk score based on this, and we did this again with another cohort of patients, again 50,000 data sets. We found the same risk factors. In addition, we found preoperative opioids as another risk factor, and we developed this risk score. As you can see, the risk score is predicting acute pain after surgery, but we are missing something because the prediction is only moderate. So still, we have the individual patient. We have to follow up during and after surgery for pain management and good pain management. And one group from the US used the European data again and just analyzed for back surgery. Back surgery is a very painful surgical procedure. And they used 1,000 data sets and again did a prediction. And they not only used preoperative data, they used the intraoperative and the postoperative data. And I would like to point out that here, as shown by the cycles, red cycles are risk factors, blue cycles are preventive factors, that we have intraoperative prediction factors increasing, red, decreasing, blue, the risk of developing acute pain after surgery. And again, and this is not surprising, but this is to be realized, intraoperative non-opioid analgesics, we know that they reduce nociception, they reduce opioid consumption, are protective factors, and that opioids in the recovery room increase the risk. So we have some factors we can change in our daily life for individual patients to reduce the risk of these patients developing acute and chronic pain. And they again developed this risk factor. They had a training cohort and a validation cohort. And again, the predictive factors are there, but they are not as good as individualizing during and after surgery our management for analgesia and for pain management after surgery. So, to conclude, we have risk factors for acute pain after surgery. Every patient is different, every surgery is different, but we have some risk factors related to the surgical procedure as well. We have some protective factors, and just to mention to you for chronic pain after surgery is even more difficult. We put that here together in a review article very recently. The risk factors for chronic pain are much more complex and probably multimodal. I will not go through this at all, but we have no risk factor yet, and this has been published earlier this year, trying to predict chronic pain after surgery. So the general conclusion here, we have a problem with acute pain management and, of course, prevention of chronic pain after surgery. More than 30% of patients develop too high pain scores after surgery. 10 to 30% of patients develop chronic pain after surgery. We have identified in many studies risk factors for severe acute pain. They relate to the surgical procedure, but they relate to the individual patient as well, and they relate to what we do with the patient during and after surgery. So I thank you very much for attention and would be delighted to listen to the next talks to hear something about how we can handle this individual patients much more precisely. Thank you very much.
Thank you.